So I'm going to use the Global Psoriasis Atlas as the exemplar of global collaborations in psoriasis epidemiology. These are my conflicts of interest. And then this is what I'm going to discuss, the history of the Global Psoriasis Atlas, how we structured it, what we've achieved to date and what we're currently working on, and how this is an exemplar for other atlases which are now starting to accumulate, and what our future plans are and how you can get involved. So I guess this sort of goes back to some work that Professor Darren Ashcroft, who is the Professor of Pharmacoepidemiology in Manchester and also the research director for the Global Psoriasis Atlas, and I were involved with about 13, 14 years ago, where we did the first systematic review of the studies that are out there then on the incidence and prevalence of psoriasis worldwide. And what we found was that the data was rather sparse, and there's no doubt that further research was required to fill those existing gaps in understanding the epidemiology of psoriasis, and particularly the trends in incidence and therefore prevalence over the course of time. And about the same time, the International League of Dermatological Societies, the ILDS, also became interested in this sort of bigger concept. And the late Professor Wolfram Sterry, when he was president of the ILDS back in 2011, 2012, and I had the great good fortune to work with him on the board of that organization, we were very impressed with what had happened in mental health globally. And they came up with this concept, or more than a concept, this construct called Grand Challenges in Global Mental Health. And we said, well, why shouldn't we try and do something on global skin health? And that's exactly what we did. We had a meeting in London, which I chaired along with Professor Rod Hay and Professor Matthias Augustin back in 2011, 2012. And we came up with this template for the grand challenges. And there were a number of different diseases that we identified which were important, were going to be even increasingly important. Of course, one of which was skin cancer, others were scabies, atopic eczema, and psoriasis. And we chose psoriasis as our exemplar, if you like, because we knew that we could probably take forward that idea because there was quite a lot of research funding available at that time, and still is, to translate into development of what became the Global Psoriasis Atlas. And really what we were trying to look at were research, education, clinical application through translation, and also the support of those responsible for the management and delivery of healthcare at local and national levels, and particularly focusing in on lower middle income countries. And at the same time, it's like a lot of things in life, things have to there's a confluence of events. The WHA, the World Health Assembly, which is part of the WHO, passed a resolution that psoriasis should be viewed as a serious non-communicable disease. And that happened in 2014. And once the WHO had done that, they wanted to know much more about this disease called psoriasis. And they produced a short but very informative global report on psoriasis. And one of their calls for action on research was understanding the epidemiology of psoriasis, the incidence and prevalence of that worldwide. And that's really was the springboard for us developing what became the Atlas. So once we had been tasked with doing that, and I was tasked with, along with Darren Ashcroft, of putting together a proposal around an Atlas, what we have been very impressed with what had happened in the diabetes community, probably about 10, 11 years previously. And that is still viewed as the Diabetes Atlas is still viewed as the exemplar atlas. It's electronic. It was set up by the International Diabetes Foundation and is still running. And the amount of data that they accumulate is really what we're trying to accomplish with psoriasis. But as you know, psoriasis and most skin disease is not quantitative, unlike diabetes, which is a very quantitative specialty working on, it's very number driven. And so it's harder for us, I think, to gather the data, but we're doing well. And our ambition It's always important to be ambitious, is to become the leading epidemiological resource on psoriasis globally, not just for the epidemiology, but also on access to care. So the funding came to, so the three collaborating organizations at the time and still are the International Federation of Psoriasis Associations, IFPA, which is the global advocate for patient organizations to do with psoriasis, the ILDS and the IPC. And with funding through the Leo Foundation, we were able to launch the study in 2016, 17, and the Atlas itself, which is a website which you can access through this URL that I'm showing you here, was launched fittingly on World Psoriasis Day on the 29th of October 2019. And that is that all the data that we've accumulated is accessible on this website. Now, the website is not just dry data about the prevalence and incidence of psoriasis in all countries around the world, but also it tells the human story of psoriasis. We have a number of very powerful interviews with patients around the world as to how psoriasis has affected their lives. The study is run from Manchester. I'm the director. Professor Darren Ashcroft is the research director, as I've mentioned. And we have in the office, we have a number of researchers and research analysts. And then Tom Rogers is our program manager, and Alice Silk is the coordinator for the Atlas. And we're very dependent, though, on our global regional coordinators and also our national coordinators. And we're currently expanding the national coordinator network. We now have, including regional coordinators, we have 44 individuals around the world who are responsible for the Global Psoriasis Atlas in their countries and regions, and are working closely with us to identify opportunities for research on epidemiology. Probably the best developed of those are in South America, but we have very good network coverage across Africa and also increasingly in Europe and other parts of the world. But so it's building very rapidly. The very first, so the key study that sort of came out of the first iteration of the Atlas is funded on a 3-year cycle. So we're currently at the end of in the 9th year of the Atlas. But one of the first studies we did was an important systematic review, which showed for the first time that there are various cancers, rare cancers, which are associated with psoriasis, which up until that time had not been known. And the more severe psoriasis, the more likely people are to have lymphoma, esophageal cancer, hepatobiliary cancer, and bladder cancer. So those are important findings. And we've now been able to replicate this by doing studies in Israel, Denmark, United Kingdom, and Taiwan to show that with a little bit of variation, those cancers are related to psoriasis, probably due to the inflammation that we find in psoriasis. One of the very first epidemiological studies we did on a country basis was naturally in the UK. And what we were able to show was that as one moves from the south of England, in Cornwall and the southwest, to the north of Scotland, the prevalence of psoriasis increases. We were also able to show that the prevalence of psoriasis in general is increasing. But that's not, as one might imagine, because there's an increasing incidence. It's because of better healthcare for the general population, people with psoriasis are living longer. Therefore, there are more people with psoriasis into older age. But the incidence is staying about the same, which is interesting because we would have thought it might have gone up with the obesity epidemic. But people with psoriasis still have about a 7-year shorter lifespan than the general population. And then probably the key study was the first proper global systematic review of psoriasis. And at that time, we were able to show for sure that at least 60 million people have psoriasis globally, so at least 60 million. And at that time, about 6 years ago, we had good data from 1 in 5 countries. We repeat this survey every so often. We've just finished the most recent rendition of that, and we now have good data from 1 in 4 countries. So we've still got a long way to go, but we're very particular about the data that we collect. And we know there's a huge variation in prevalence across the world, being rarer in Southeast Asia and East Asia. So 0.06% of the population in Taiwan to close to 2% in Northern Europe. But what do we do with that data? What do we do with the areas where we don't know, where we don't have good data? So there's particularly sparse data from sub-Saharan Africa. There's only one good study, which was actually performed by a medical student many years ago, who then a man who then, Sam Gibbs, who then became a dermatologist. And he did a very careful study, household to household study in northern Tanzania, and found 1 case of psoriasis in 1,000 people, saying there's a prevalence of 0.1%. And armed with that information, we did our first field survey. So to really get the best data, you go to where the patients are. So we were hosted by Moshi, the Regional Dermatology Training Center in Tanzania. We saw they brought together their psoriasis patients, but they only have 31 dermatologists for a population of 57 million people. Some countries, as you're aware, have even fewer dermatologists, if any at all. And what we found was that in most cases, there is a misdiagnosis of psoriasis in the community, and that it's diagnosed as tinea corporis. Topical therapies are those written here, mainly coal tar and salicylic acid and betamethasone. And methotrexate was the only systemic therapy available, but that was only used for a few months at a time because there's a very large distances that patients had to travel. We did a field survey. We only saw 300 people, MassEye people, but we found that no psoriasis, which actually probably backs up what Sam Gibbs showed all those years previously, is that we might not have expected to see any patients with psoriasis in 300. But what came out of that was the first ever study publication by one of the registrars with us at that time, Citra Khan, who's now a sort of global leader in global dermatology, the prevalence of skin disease in the MassEye people. And that's an informative study, and there's sort of the summary of what we saw during that field survey. As I've mentioned, in low and middle income countries, and whether we've worked in Lebanon or Tanzania or elsewhere, the diagnosis of psoriasis is often missed completely or delayed by many years because most people are never seen by a dermatologist, and the default diagnosis is tinea corporis. Also psoriasis, and we have a big interest in this with the IPC, psoriasis presents differently in darker skin tones, not just the color of the lesions, but also the pattern of distribution is different as well, as we're starting to find. And working closely with our colleagues at the IPC, we did an eDelphi study where we had 50 dermatologists representing 27 countries. And through this iterative process, we sieved down what are the key clinical diagnostic criteria. And not too surprisingly, we come up with one essential one, which is a well-demarcated lesion with or without silvery white scales. Then at least 4 of these 8 that you see here. And very importantly, we also highlighted the fact that in dark skin, this would be different. It would be gray or silver or purple in color rather than pink or red. But of course, giving non-dermatologists just these written data is not really going to help them make a diagnosis in the field. So you need to have illustrations. Now, I don't know how many of you who are listening to this lecture are bird watchers, but if you went out into your local wood or park and wanted to identify the birds there, the field guide that you'd have wouldn't have photographs in it. They would have an artist's drawings or paintings of those birds highlighting the key diagnostic features. So we used artist illustrations of psoriasis as a companion to those written descriptions. These are the sort of things we produced in dark skin tones, nail changes, etc., etc. And using those together in a study we did, so these are some further, this is what the nail changes look like. And then we did a study in non-dermatologists in the UK, GPs, nurses, pharmacists, and found that this diagnostic tool, if you like, improves the ability of non-dermatologists to make an accurate diagnosis of psoriasis. And we're now trying this around the world to see if it works out in the field. And I think by improving the diagnosis of psoriasis will be one of the major ways that we can improve the management of psoriasis worldwide, by getting the diagnosis right, getting dermatologists to see the patient. But of course, doing field surveys, and one always thinks of global dermatology, tropical medicine, if you like, they're not synonymous. Global dermatology is also in remote areas, not necessarily the global south. And our second survey, which was delayed by, as you can imagine, by 3 years because of COVID, was actually in Greenland, in a very remote part of Greenland in the eastern seaboard. Very difficult place for us to get to. We had to get there by helicopter because the sea was frozen at that time. We had 8 dermatologists, mainly from outside, all from outside Greenland. We had two of them for Denmark. We had coordinators and interpreters who were interpreting. This was a mainly Inuit population, interpreting Eastern Greenlandic for us. But if you read the textbooks, psoriasis does not exist in Greenland. But interestingly, we saw 17 people with psoriasis. And the reason that it didn't seem to exist was because it had been overlooked. And I'll show you a photograph. So it was overlooked because it looks a little bit like eczema or dandruff. And it's not classic psoriasis as we would see in the textbooks. So that is the importance of going to these places and be able to see patients firsthand. And also their access to care was very poor. To be on a biologic therapy, for instance, this would have to be a very involved process, liaising with dermatologists back in Copenhagen. But we were able to publish this work in the International Journal of Circumpolar Health. We're working here with one of our colleagues from the meeting today, Professor Chun, using their very sophisticated healthcare record systems to be able to do a very detailed electronic patient record survey of psoriasis in Johor Bahru district, state of Malaysia. This was published in the British Journal of Dermatology. And what we were able to show was that the prevalence of psoriasis in Malaysia is about 0.34%, but there's marked differences across ethnicities. So it's much commoner in the Indian population, a little bit rarer in the Chinese, and much rarer in the Malay population. It also presents earlier in women than men, but the prevalence overall was about the same. And that's important. So it shows that by doing these studies that you can actually start to look at the different contributions of the ethnicity. We did a similar study in Taiwan. Interestingly, commoner in men in Taiwan, and also for us is that late onset psoriasis occurring after the age of 40 was different from what we would see in Western countries, where about most patients present with psoriasis before the age of 40, so-called early onset disease, whilst in Taiwan, it seemed that the majority of patients, 60%, the diagnosis or the presentation occurred after the age of 40. Also in Taiwan, we looked at risk of serious infection. So, obviously we're interested in epidemiology, but also we found that psoriasis per se has a higher risk of infection compared with the general population. That's probably because of the staphylococcal carriage on the skin. Working with our colleagues in Brazil, with Professor Ramiti, who's an IPC counsellor, we were able to do a study in the Brazilian Amazon rainforest, very remote area, looking at the Yanomami indigenous population. This is an area that is only accessible by light aircraft, and we were able to assess over 500 people. And the key thing was that we found no psoriasis, no atopic dermatitis, and no urticaria. And so that implied to us that lack of environmental triggers may be a role in this. And we were able to follow this up by having access to the epidemiology of a lot of skin diseases using the Brazilian indigenous people database, over 750,000 people. And what we found was that as these populations become more urbanized, you start to see atopic dermatitis and you start to see psoriasis, which implies that environmental influences are important on the background of a genetic predisposition. We work closely with the IPC in developing, we were hoping to do a visit to Myanmar, Burma, as you heard in the introduction. We're working with Dr. Sue Lewin. We have a charity, UK-based registered charity in Myanmar, but because of the military coup there, we were unable to enter the country, but we set up and ran a series of masterclass webinars with the IPC, not just for Myanmar, but also for Laos, Nepal, and Cambodia. And importantly, and differently in previous webinars, we actually included non-dermatologists. So GPs and nurses were also part of those webinars, and they found them extremely helpful. And that's a template for future work. The most recent skin disease survey that we've done was actually in December 2023, working with Professor Nicole Zadalova, who's a very eminent dermatologist. She was at that time the dean of the medical school in Durban. And we did the most thorough and probably the template blueprint now for doing a field survey in two rural townships in Eastern Cape in South Africa. So here in the Eastern Cape, very remote areas, and we were able to do a very detailed study with working with Professor Nicole Zadalova and her team. And these were these two rural villages. One had about 500 inhabitants, the other just over 1,700. And we literally went from house to house because we're interested not just in the people who have skin disease, but also the people who don't. And you can see here on the bottom left-hand side, these houses are spaced very far apart. So it was a very arduous work. We had dermatologists from Europe and from Israel and from other countries working with dermatologists from South Africa, but also we needed interpreters, community health workers, because the predominant language was Xhosa. So we had a community hall in both sites, which is where we saw patients who happened to have psoriasis or other diseases we might be interested in, such as atopic dermatitis. We worked with Professor Carsten Floor, who I'm pointing to here, who's the director of the Global Atopic Dermatitis Atlas. And you can see that we had a big team, including industry volunteers who were there on their corporate social responsibility opportunity. So it's hard work, but very worthwhile. These are the people that we saw. We saw adults and children. And as I mentioned, nearly all patients were from this Xhosa population. And the skin diseases we saw, and people say, well, we couldn't possibly do work like this. We don't know anything about tropical dermatology. Well, the main skin diseases we see are those that you would see back home in your regular clinic: acne, tinea capitis, melasma, seborrheic dermatitis. We did see psoriasis, but it's rare. Only about 0.4% of the population had psoriasis. And it presented a little bit differently because these cases were linked to an HIV infection. So that's, again, is something we learned about seeing patients in the field. Also, the presentation of other skin diseases in darker skin. And this is hopefully going to be published in the British Journal of Dermatology later this year. So we're now in phase 3. We're now sort of coming to the end of phase 3 in our 9th year. We're still interested in epidemiology, but now we're interested in global generalized pustular psoriasis as well. We're also continuing that work on the early diagnosis of psoriasis and also comorbid disease, and doing more detailed work now on the health economic impact of psoriasis to the individual and to society. This is the team I mentioned earlier. So an away day that we had last year. This is Professor Ashcroft at the back here, Dr. Wright, Alison Wright is one of our research analysts, and Tom Rogers and Alice Silk. And then this is the team at a recent meeting in the EADV in Amsterdam last year with colleagues from the IPC, IFPA, and also the ILDS. And this is Henry Lim, who's the president of the ILDS and chairs our board. Other studies which are of interest and which are ongoing, working with Professor Wayne Gulliver, who is out in Newfoundland on the eastern seaboard of Canada. They have been following up patients with psoriasis for many years. There's a very high prevalence of psoriasis in Newfoundland. It's about 6% of the, 7% of the population, but that's interesting for sure. But what is even more interesting is that there are some townships there where the prevalence of psoriasis is 40%. And that does seem to link with historical high incidence or high prevalence of TB in those particular populations. And we are exploring this in more detail. The reason I put asbestos mining there is because these townships are also linked to very large asbestos mines. And then finally, Professor Chun will be very happy I'm going to mention this, but we have a particular interest in generalized pustular psoriasis. This is not psoriasis, it's a different disease, but we are interested in it. And we're using the global psoriasis expertise to actually look at prevalence and incidence of GPP, because there's very few robust studies on this disease. And again, working with Professor Chun and colleagues, we're able to use the same database and look at GPP, which was a nice contrast with what we've done with plaque psoriasis. The prevalence is much lower than you would find in plaque psoriasis. And remember, I told you that it was plaque psoriasis was commonest in Indian population and then Chinese and then Malay. This time around, it's switched around and that it's commonest in the Chinese, followed by Malay, followed by Indian. And obviously that means genetic background plays an important role. Now, what about our research? We've had a number of IPC fellows who've worked with us. But in fact, the very first one was Daniela Amahu from Chile, who's now a leading psoriasis advocate back in Chile. And then more recently, Jacqueline Barbosa da Silva from southern Brazil worked with us and did a very nice questionnaire study, which was recently published in the International Journal of Dermatology, the lived experience of people with psoriasis in southern Brazil. And we're now using this as a template. Dr. Brian Guevara, who was with us previously, has done a similar study out in the Philippines. And we're hoping that our latest IPC fellow, working with Professor Ashcroft and myself, we will also look at the lived experience of psoriasis in Burundi. Now, what about future field surveys? Well, these are difficult studies to do. We have to have a very strong on-the-ground team. And it's now looking very likely that our next field survey will be in the Philippines, where we have very little good data. And that's going to be spearheaded on the ground by Dr. Brian Guevara, who I'm showing here, who was our IPC fellow last year. And we've got very advanced plans now working in an area in this area, which is called Cebu and Bogo City. We now have 3 other atlases which have come together on the back of the Global Psoriasis Atlas. The Global Hidradenitis Suppurativa Atlas, led by Professor Gregor Yemek, Vitiligo Atlas, led by Professor Ezzedine from Paris, and the Global Atopic Dermatitis Atlas, led by Professor Floor from London. And these teams are working together, and certainly for the Philippines study, we're hopeful that all 4 atlases will be out there in the field, working also with Professor Esther Freeman's team from the Skin Observatory. Now, these are the leads of those 4 atlases, and these are our supporters. The Leo Foundation, not Leo Pharma, but Leo Foundation are our main supporter, but we have a number of other industry supporters who allow us to do the work that